Hello, everybody. My name is Hemasat Alkhatib. I'm a chief resident here at Metro Health in Cleveland, the hometown of SAGES this year. So welcome all. It's been nice to have you. I'm going to present our work, Esophageal Impedance Planimetry during per-oral endoscopic myotomy guides myotomy extent. And I would like to thank SAGES for the opportunity to present. There you go. Our authors have no disclosures to report. Briefly, just to go over what functional luminal imaging probe technology is. It's a balloon-based catheter, and it has these electrodes along its length that use impedance planimetry sensors to give you geometrical measurements of your sphincter. And in our case, this is the lower esophageal sphincter. And it takes that data and it gives you a visual representation of what you're seeing in real time. And there are two main values that we look for that are most commonly studied: the diameter and the distensibility index. The distensibility index is basically a surrogate for compliance. And so if your sphincter is tight, which you can actually see here on the hourglass shape with warmer colors, that usually means that it's less compliant. And in patients with achalasia, that's what you would expect to see. So how do we use flip technology in POEM? Looking at POEM goals, we are usually aiming for adequate myotomy length that ensures symptom management, but we also want to think about mitigating the reflux risk. And that's been studied in the literature by other Foregut institutes to try and correlate specific values that we obtain with EndoFlip with those outcome measures. And so although it's very variable and can be inconsistent currently, we have a kind of an idea. So we know that if the DI is less than 3, usually that correlates with worse symptoms. If we're about 4 to 8, we're kind of looking at ideal values with better outcomes. And then if it's greater than 8, we're looking at worse reflux for patients. And so in terms of diameter, it is less studied, but there is a study out there that says if it's greater than 11, then we are worried about more reflux. So for us, what was our study question? We wanted to use this data in our own patient population and see if flip-guided myotomy can evaluate the adequacy of our myotomy extent when we're performing our standard of care myotomy. And the other thing we wanted to look into is for those patients that had symptom recurrence after the POEM procedure, if flip was useful in their diagnosis and guiding their treatment. So our patient population, this was a single institution study, and all surgeries were performed by a single surgeon. We identified 14 patients that underwent a POEM procedure with the use of flip intraoperatively. These are some basic demographic data. Our mean age was 56, mean BMI 28, and the majority of the population were female. When we looked at their peri-op details, none of these patients had a prior myotomy, which is important for us to know. And then in terms of operatively, they all underwent our standard of care myotomy. So for us, that includes about 10 centimeter esophageal length that we then extend about 3 to 4 centimeters distal to the EG junction. And then we prefer a posterior myotomy, and so we perform that in 86% of the patients. When it is prohibitive, then we would perform an interior myotomy. And then flip values, we obtain them before the myotomy and after the myotomy. When looking at the flip values in our patient population, you can see here the distensibility index, DI and Dmin, which is the diameter. Our starting points are 1.4 for the distensibility index, which is that's how you would expect achalasia to present with that low of a number. And again, DI, the lower the number, the less compliant your sphincter is. And then the diameter is tighter. And you can see post-POEM, all our numbers increase, which means that we've made the LES more compliant and wider, and that theoretically will help the food bolus go through easier. So did we have to change? Oh, this is a visual depiction of how you see this intraoperatively. And you see on the pre-POEM side, those warmer colors indicate a tighter sphincter. And after your myotomy, you can see the diameter has increased and your compliance has gotten better. And so the next question is, did we need to change any management intraoperatively based on these values? And for one patient, we did. And if we look at the numbers, you can kind of see why. So pre-POEM, this patient, baseline distensibility index is 1.4. Post-POEM, we did have some change with increase to 3.4, but if I can remind you that our mean DI was about 6, and we usually try to get these patients closer to 4, where our ideal values lay. And so we actually performed 2 additional myotomies and repeated flip. And you can see that DI didn't change much with the additional myotomy, but our diameter kept increasing. And at this point, we started worrying about reflux for this patient, and that's why we stopped any additional myotomies. When we're looking at outcomes, in short-term follow-up, we had 100% of our patients follow up. We used the Eckert score to evaluate for treatment success. And overall, our Eckert score went from 7, which indicates worse symptom control pre-POEM, and then down to 2, which indicates good symptom control post-POEM. In terms of major complications, 1 patient had a submucosal tunnel leak that was managed non-operatively with bowel rest and a distally placed nasoenteric tube. And then a second patient with a history of DVT-PE developed a PE post-procedure. When we looked at symptom recurrence for our patient population, we looked at their entire follow-up period. And for us, about 80% of patients had a long-term follow-up with a mean of 15 plus minus 9 months. In the early postoperative period, 4 patients reported symptom recurrence. In the late postoperative period, 1 patient reported symptom recurrence. For 1 patient, there was spontaneous resolution. We did a timed barium that was normal, and as we continued to follow the patient closely, their symptoms resolved and their Eckert score dropped from 7 to 1. 1 patient was diagnosed with treatment failure that was confirmed in manometry and timed barium. And then the remaining 3 patients had non-confirmatory workup. 1 of them did not tolerate manometry, 2 did not schedule their manometry, and then 4 had inconclusive timed barium studies. And so for those 4 patients, we recommended repeat EGD with FLIP. The outcomes of the FLIP values are here. First, I have post-POEM, and you can see that all these patients had good DI values at the end of our initial myotomy, and those are approximate ideal values, so none of them had really lower DI that would be concerning for recurrence. And you can see actually FLIP values when at their time of recurrence did decrease, and that indicates that there is some LES dysfunction that was not picked up on the prior studies. And so for all 4 patients, we recommended EGD with dilation and Botox. 3 of them had resolution of their symptoms, and then 1 was refractory and required a PEG tube for nutritional support. So when we look at their second question, we wanted to see the utility of FLIP in the workup of symptom recurrence. We found in 75% of our patients that had symptom recurrence, we needed FLIP to be able to identify pathology that was specific to the LES, so then we can refer them for LES-directed therapy. There is a question of a role of FLIP in assessing the treatment response for these patients, but we do not currently employ it. In conclusion, when we perform a standard length myotomy at our institution, and we use FLIP to identify the adequacy of this extent, in the majority of our patients, the ideal values were reached. And so this begs the question, can we have comparable outcomes with shorter myotomy that is guided by FLIP? And then FLIP, for us, helped in diagnosing symptom recurrence for these patients and helped refer them for LES-directed therapy, which then resulted in symptom resolution. And I think very important, despite its potential, the FLIP utility in POEM has been very variable in the studies published, and that's likely because there's different variables that can be used as proxy to measure outcomes. Thank you.